Chronic liver disease. General features. The only common cause of hematmesis associated with abnormal physical signs is chronic liver disease, and the statement that the patient had a brisk, painless, large volume hematmesis is clearly a pointer to varices. In routine practice, your first concern would be to assess the state of the circulation, but patients who are actively bleeding will not, or should not, appear in PACEs. What evidence of chronic liver disease might be apparent from the end of the bed? General appearance: is the patient cachectic? If given the opportunity to ask, say that you would like to know his weight, height, and BMI. Gynecomastia: loss of secondary sexual hair, in men, tanned appearance, consider hemochromatosis. Skin: jaundice, spider nevi, bruising, scratch marks, tattoos, signs of intravenous drug abuse, risk factors for hepatitis B and C. Hands: liver flap, clubbing, leukonychia, palmar erythema, Dupuytren's contracture. Eyes: jaundice, anemia. Mouth: angular chyle ossus, poor dentition. Abdomen: may be obviously distended. Legs: tissue paper skin, peripheral edema due to hypoproteinemia. Also look for the following. Cushingoid features, suggest long-term steroid treatment. Pigmentation, consider hemochromatosis, bronze diabetes. Telangiectasia on the face, lips, and within the mouth. These would indicate that the patient almost certainly has hereditary hemorrhagic telangiectasia, a rare autosomal dominant condition associated with gastrointestinal bleeding that appears in medical examinations, including PACEs, with inordinate frequency. Abdominal examination. Comment on the presence or absence of the following. Distension. Prominent anterior abdominal wall veins with flow away from the umbilicus, caput medusa. Hepatomegaly, but remember that most causes of chronic liver disease are associated with a shrunken liver. Listen for a brute. Splenomegaly, the key physical sign indicating the presence of portal hypertension in a patient with chronic liver disease, although the absence of splenomegaly does not mean that portal hypertension can be excluded. Ascites, test for shifting dullness. Rectal examination for the formal assessment of melanoma remains essential in routine clinical practice, and a comment to this effect would be appropriate in PACEs. Further discussion. What are the common causes of chronic liver disease? Common. Alcoholic liver disease. Chronic viral hepatitis, hepatitis C or hepatitis B. Non-alcoholic steatohepatitis. Less common. Autoimmune liver diseases, primary biliary cirrhosis, autoimmune hepatitis, primary sclerosing cholangitis. Cryptogenic or idiopathic, represents probably less than 20% of cases now. Rare. Metabolic and genetic liver diseases, alpha-1 antitrypsin deficiency, hemochromatosis, Wilson's disease. Infiltrative liver disease, sarcoidosis, amyloidosis. Miscellaneous, secondary biliary cirrhosis, prolonged total parenteral nutrition, cystic fibrosis, chronic heart failure. In what diseases can patients have variceal hemorrhage but not chronic liver disease? Portal hypertension can be divided into prehepatic, hepatic, and posthepatic types. Prehepatic. Increased flow, e.g. arteriovenous fistula, massive splenomegaly. Portal or splenic vein thrombosis, e.g. pancreatitis, malignancy, sepsis, thrombophilia. Portal vein stenosis, e.g. post-liver transplant. Hepatic. Presinusoidal, e.g. primary biliary cirrhosis, schistosomiasis, congenital hepatic fibrosis. Sinusoidal, e.g. cirrhosis, acute alcoholic hepatitis, fulminant hepatitis. Post-sinusoidal, e.g. veno-occlusive disease. Post-hepatic. Hepatic vein outflow obstruction, e.g. Budd-Chiari syndrome, heart failure, inferior vena cava web. Thus it is possible to have normal liver function and still bleed from varices, the commonest causes of this in practice being portal and splenic vein thrombosis.